Good evening, everybody. We are waiting still for Professor John Middleton to connect. So there are some technical glimpses. So sorry for this. We'll start very soon. So please be patient, and we'll start in a couple of minutes. Excellent. John, I see that you successfully connected. So let's check only if audio is working. If you can.
Muted.
Excellent, excellent. So it is working, right? Excellent. So excellent. Good. So maybe we can start.
Share screen. I've got disabled share screen at the moment.
Yeah. I think in a minute, let's leave this what is now landing slide, and I will shortly introduce you, and then you can share the screen if we can do like this one. So if it is okay with you. So
Yep.
Good, excellent. So hello and welcome to our public health webinar. My name is Michael Grievin. I'm professor and director of the Institute of Public Health at the College of Medicine and Health Sciences, United Arab Emirates University. This webinar is a part of the global campaign, This is Public Health. We are also very proud to be affiliated with ASFER, Association of Schools of Public Health in the European region. We are organizing our webinars monthly on every third Tuesday. And aim is to bring interesting speakers in order to highlight different important public health issues. Today, in this webinar, you will be able to ask questions in the end. You can do so even by clicking on the QA option in the middle bottom of your screen. You can submit your question during the presentation, and we'll try to cover as many questions as possible. Of course, it depends on the time. Now, allow me to introduce our speaker today. We are really very honored that our invitation was accepted by John Middleton, current president of ASFER. John is also past president of the Faculty of Public Health of the Royal Society of Physicians, UK. He leads ASFER strategic development and chair ASFER COVID-19 task force, whose extensive materials for teaching and advocacy can be found on the ASFER webpage. He was director of public health for Sandwell in the West Midlands of England for 27 years. His professional interests are in community safety, community development, climate breakdown, and environmental protection. And his main hobby is music. He's a blues harmonica player with Dr. Harp's Medicine Band. So title of his presentation today is Planning for an Outbreak of Health, Lessons from the Pandemic for the Health of the Public and the Public Health Service. So John, the virtual floor is yours.
Thank you. I've got host disabled screen for the sharing at the moment.
Ismail, can you assist into like open?
Yes, you can try now. I removed it.
I knew this would happen. I've got my slideshow open. Is that it? Okay, so thank you very much for that introduction, and thank you everybody for joining us for this webinar. There's never been a more important time for people to be in public health, and there's never been a more necessary time. I've said this since about 2010, I think, when the era of austerity, the obvious impacts of climate change, of global conflict, of environmental degradation, and a whole raft of reasons. But clearly with the pandemic, we see an urgent and pressing need for a greater public health involvement, a greater recognition of the skills of public health professionals. So I'm afraid you caught me at a disadvantage, because I haven't worked out the time differences and was expecting another hour to prepare. But in any case, here we go. This is the onset of the pandemic in China, we think, in late 2019. And as people say in relation to the military images of this pandemic, combating the virus, fighting the virus.
John, I'm sorry, we cannot see the slides. If you are sharing the slides, we cannot see them.
Oh, okay.
It is possible even like to send to Ismail if you want, and he can upload.
Yeah, we can. Yep, could we take a quick break to do that, maybe? Sorry, I shall need to do that by a Dropbox link, because it's quite a big file. Sorry about this, folks.
John, Ismail will explain you. It is possible to share even.
Professor John, you can share your screen. I made you co-host. It is.
Oh, that's right.
So if you can just click on the share screen, and it should be working.
I've got a.
Apparently, there is bottom in the bottom. There is some share screen, some like square, so you can.
Yeah, no, I've got that. I need to. It's privacy. Hello.
Hello, Professor John. Yeah, we can hear you.
Yeah.
Yeah, now we
okay.
can see your screen. If you just open your slides now, it should be okay.
Got it.
Almost there. Yes, it is. It is coming. Excellent.
Okay. All right.
Great.
Let's start.
Perfect.
Right.
Great,
You can close down the recording and start again. Okay. Right. Welcome again, everybody. Let's So, as I said, there's never been a more important time for people to be working in public health, never been a more necessary time. And in the course of what I have to say, some of it will be about the health of the public, which should be everybody's business. We need our surveyors, our engineers, our lawyers, our environmental scientists. All of these people play a vital part in protecting and improving the health of the public. But we also need a skilled and knowledgeable public health profession, a public health service, a public health system, which can be the essence of protecting and improving the health of the public, because we need that special expertise that we can bring to the idea and to the insights into population health. Now, I'm going to start from a sort of history of the current pandemic, which is clearly the reference point that we all have for the importance of public health. And it's shone a clear light into what public health professionals do and why they're needed. But it's also caused us problems. It's also been a time of tension and unrest with politicians in different nations and different political regimes. The military imagery of the fight against pandemic, I think, is more and more relevant, actually, as I see with the first casualty of war is truth. And we saw very early on in the outbreak the loss of at least 5 people in China arrested for speaking out around the coronavirus, including the most prominent Dr. Li Weiyan. And we've seen in other circumstances how public health professionals' advice and knowledge has been ignored or has been rubbished, and how we have needed to see figures in the public health world stand up. This is the Johns Hopkins map of the world in about March of 2020. Already the virus was present in 5 continents. Why we were still waiting for the announcement of a pandemic is a subject for some question, perhaps. But the lessons were already coming out from the Chinese experience. This is the epi curve for Wuhan, published by Pan et al. in JAMA in April 2020. And it shows clearly how the lockdown that was implemented in Wuhan, January the 22nd, started to lower the epi curve after about 3 weeks. But then centralized treatment and isolation came in, and that took the R from 0.7 with the lockdown down to 0.2, and the very clear closure almost of the outbreak at that point. Meanwhile, in some Western governments, there was an area of inactivity, a feeling that this was somebody else's problem. This was something that we could cope with our more sophisticated NHS, perhaps. And there was a general area of activity too little and too late. By May, we saw a much more extensive pandemic, clearly across all 5 continents, and much more human suffering and misery. Countries like the US, which had ignored the pandemic, suffering immensely and continuing to do so. In March this year, ASFA produced its first statement on the coronavirus pandemic, and we drew attention to the the problems of the pandemic itself, the threat that it posed, but we also called for investment in public health services and rebuilding of public health after the pandemic, with emphasis on education, training and capacity. And we established a task force of our members. Our members come from 44 of the 53 countries in the European WHO, and we have about 110 members, of which about 30 have been active in some way with the task force. So there was the ASFA statement that was published March 29th in the International Journal of Public Health. And we went on to undertake a number of areas of work. Early on, we joined a call of Physicians for Human Rights Israel in seeking to protect the health and improve the health of Palestinians in the pandemic. And most recently, we've published a call to provide vaccination for Palestinians. We were involved in a range of specific areas of interest of our members. The strategic development on use of masks came in very early. We were very active on issues around testing and the limitations of it. And our colleagues in Italy were very much at the sharp end, and this was their period prevalence study as at the 7th of April. Again, we think showing how the lockdown worked in effect, confining the major part of the pandemic in Italy to the northern regions, and those that hadn't been affected were in effect protected from further cases at that point. We put out our own call that the World Health Organization, which was under threat from President Trump at the time, should be supported, and that any issues of analysis as to what failings there may have been with WHO should be put to the end of the pandemic. And indeed, we placed our support behind colleagues both in the European region and generally, and we think that call was vindicated. In the UK, there was some very good work early on in the impacts of the COVID pandemic in terms of the lockdown, and some very detailed work on the issues of COVID in minorities, and race and ethnicity were, black men were 4 times as likely as a white man to die from COVID. And there were a range of risks involved, including high exposure, high risk occupations, use of public transport, and pre-existing health risks, but also issues of institutional racism, people feeling that they're not being listened to, not being provided with adequate protective equipment, and those were all put out through a Public Health England report by Kevin Fenton. And indeed, those problems have been retained still. We see them throughout the period of pandemic to the present day. In August, we published our concerns about a second wave of a pandemic COVID at a time when many of the political commentators were saying it's all over, that it was no more severe than flu, and that it wasn't a problem anymore. We and a lot of other commentators said, actually, there's no reason to believe that this won't recur. And sure enough, enough, it did. The Academy of Medical Sciences in the UK suggested that there could be 150,000 further deaths. The Scientific Advisory Group for the UK government said 85,000. Well, we've actually just about reached the 85,000 now. So, and I published in the BMJ at the time, indicating that not just problems of the COVID pandemic, but problems of a very cold winter, potentially problems with a serious flu epidemic, which we haven't seen, but also for the UK, particularly our problems with Brexit. And we have yet to see the worst impacts of Brexit. At the time in the summer, there was this, as we were being taught that the disease was going away, we had what I call the dance macabre, the weekly Monday press conference. The Minister of Health would tell us how the death rate was going down, and ignoring the fact that Mondays was always the lowest reporting from hospitals. And if he'd waited till Tuesday or Wednesday, the numbers would be back up. At that time, our numbers were equivalent to about 5 or 10 New Zealand equivalents. What they'd had in the whole pandemic, we were getting in a day. So it was a period of false hope and false promise that we were going to be liberated from the pandemic. Roy Lilly, a commentator on the NHS, in one of his many lucid blogs, suggested that there were 7 rules for managers, leaders, and for whole governments. Number one of which was about communicating clearly. Announce when you're going to do your lockdown statements. Management by mumbling doesn't work. And his second rule was avoid mixing messages. And there was a speech that Mr. Johnson made to his MPs, 50 MPs crammed into a tiny meeting room in the Commons at a time when he was telling the public that they should all be 2 meters apart. He actually told them that they should be cheek by jowl in a short time, and that again, mixed messages, not good for the public to hear. Don't fudge to be popular. He was also accused of leaking information to the press in May, prior to the first lockdown coming off, in which it became called Magic Monday, the day that these restrictions would be liberated. And there were problems of issues between the English government and the UK as a whole, with our neighbours doing different policies and no coordination between the two. And it was also quite clear that some of the messaging was just not deliverable. This particular one, crystal clear that drunk people won't socially distance, sometime in July, that one. Be clear about how your decisions are made and transparent about where the data is coming from. That should be self-evident, I think. But it wasn't. There were data on care home deaths were kept secret to protect commercial interests. They move a bit fast. And being honest, we've had certainly a clear failure of messaging throughout the pandemic, with dishonesty, disinformation, and people at the top not being joined up about what they're saying. Good managers manage the message. And his conclusion on this was that history repeats itself. Want of foresight, unwillingness to act, indecision, inability to accept advice, be truthful. Time and again, governments fail to do the simplest of things. But I would add to these, don't be incompetent. In Leicester, a major outbreak was not known to the public till several weeks after it was clearly there in the data, because there was a separation of where the data sources were, and the pillar 2, the red data, wasn't shared with the Department of Health and Public Health England because it was done by the private sector. So a major epidemic needed to be controlled in Leicester, and it still hasn't really. Don't get your testing wrong. Shortages in test materials sent people invitations to go 300 miles to get a test. And this debacle of personal protective equipment not being of an adequate standard for medical use has been repeated many times over. GPs sent used gloves, but we've also seen those areas of incompetence and negligence really repeated across the populist world, I would say. There's Johnson in the background, Mr. Trump, Mr. Bolsonaro, I think you'll find, and really the populist governments have not done well in this pandemic. Don't be negligent. There is a legal entity called corporate manslaughter, and it's not totally clear yet as to whether our government has acted in a way that could be regarded as corporate manslaughter. Don't be corrupt. Who has profited from the coronavirus spending spree? Many people close to government, many donors to the Conservative Party. Now, the government in the summer was facing legal action, and in fact that legal action has taken place, and ministers this week were found to have acted unlawfully, which should have been a resignation matter, but mysteriously isn't. Let me go on to the sort of the experience by the autumn. I did a blog called The Three Faces of COVID. And it seemed to me by that point that there were those countries that had done well right from the start. We know about the Far Eastern examples with Taiwan, Singapore, Japan, and so on. New Zealand, of course. But there were some other countries that also did extremely well. Mongolia, Vietnam, Ghana, Rwanda, Trinidad, Uruguay were all did very well, and I think it was because they actually took notice of what the WHO was saying in January. They weren't sophisticated public health systems with large numbers of modelers. They were people who just followed the basic advice about hygiene, about droplet spread, about keeping health and care workers safe. And in the case of Mongolia, for instance, they actually repatriated some of their nationals from Wuhan safely with isolation, quarantine, and they didn't see an outbreak because they did the basics. So that's that was the position in December, with the United States and Sweden put on the graph for comparisons there. And there's another presentation of it with the confirmed cases. You can see it quite dramatically with the log scale that all those countries at the top relative to, I can't see it because I've got people's faces in front of me. So we've got a group of European and other countries there at the top with rates sometimes in excess of 1,000, that of New Zealand and Vietnam, and all characterized, I would say, by not taking that same notice of what WHO had been talking about from January. There was also in the autumn a resurgence of interest in the idea of herd immunity. That if the virus ripped through populations sufficiently, everybody would be left with a level of immunity that would see the pandemic die out. We published a paper with ASFA and also with the Italians in the International Journal of Public Health, which urged caution about the idea of natural herd immunity. At the time, Manaus in Brazil was being trumpeted as the example, where 76% of the population had suffered from COVID, had been infected sometime in May, June. And that was being heralded in the first Lancet paper as an example of natural herd immunity. But in fact, the virus has re-established and taken off, and there's no signs of an abatement of misery and death in Manaus. And two further papers have demonstrated how that is still going on, probably with new variants of virus. Again, the new variant issue being the case for not accepting, allowing the virus to just go its way. The more it's able to replicate, the more opportunities it has to create new variations. And there is just featured in recent times in the news, mass graves, mass hospital filling, and the third wave in Brazil still going on. So I'd like to move on to the title really of my presentation, which is Planning for an Outbreak of Health. There's been a lot of interest in the idea of building back better, that with the hardships that people have endured through the pandemic and through lockdowns, that the future has to be a better future. And that is both from the point of view of the health of the public, the big social interventions we can make to improve people's lives, but also I think the health of the public health system, that we do need to ensure that we rebuild public health, that we ensure there are more skills being grown in schools of public health and other public health services. This report here, Build Back Fairer, was another of Michael Marmot's reports calling for investment in better social conditions, better housing, fairer wage, fairer reductions of income inequalities, and how we can build a better community for all our people in the future. In lockdown one, we saw the brief glimpse of what might be possible in terms of reducing our reliance on internal combustion engines, and how this was the imagery of air pollution over China during the Wuhan lockdown. And we also saw the same repeated many times over in European cities. This is Milan, and people were taking more active travel where they were traveling at all. In our publication in the European Public Health Alliance newsletter, we called for a strengthening of both the health of the public, the policies that determine how healthy people can be, but also about growing the public health workforce. Now, I'm not sure, there may be a second section of this, but what was apparent, what's always been apparent, is that whatever we think about conventional experience of pandemics, we can never say that we've cracked this one. Trump's infamous no American deaths, Jacinda Ardern's 100-day party for being COVID-free, instantly followed by new cases. And the Charles Bridge disaster in Prague in Czechia was really actually the party to celebrate the end of the pandemic, and Czechia, having done so well, is now on the brink of a health service collapse. And it's gone from being hero, I'm afraid, to zero, really. I want to say a little bit about ASFA's general work that we try to keep going alongside our pandemic work. You would expect us to be strongly involved in all aspects of public health education, competence development, curriculum, working on workforce strategies, growing capacity in public health, forming alliances, and growing ethical and ethics and values and ethical codes of conduct. And this is our core competence list. This is what schools of public health are able to use as checklists, really, for their master's courses. That's the list of what's in there. We are currently working with ECDC, the European Communicable Disease and Surveillance Organization, to revise the infectious disease competencies, something that's both timely and necessary with the lessons of the pandemic. We also produced a competency framework for the public health workforce, and that's a complementary document which with WHO, which helps to assess the public health strength of the workforce in a country, or it could be in a local area. It's both individual and collective, really. We can't all be experts on every aspect of public health, but we need to ensure our systems are competent. This is a reflection of the website for our task force. I do commend it to you. We've had a huge outpouring of new items in January and February, including some of the ones I've already mentioned. We've revisited the testing, and we've also produced this booklet called How to Count Illness. We thought it was for press and the general public, but I think actually some of it's quite suitable for bachelor students and students in other clinical areas, perhaps, who are not experts in public health. That was the containment measures in Italy. There's the testing again, sorry about that. And again, we used the Italian example, and that was looking at the positive predictive values and showing really just some of the limitations of screening in this case using PCR, but now of course we have that with problems with lateral flow tests as well, and most recently, a group of ours have produced a video on the limitations and considerations for screening. We've done a great deal of work on inequalities and vulnerable populations. And our young professionals group is very active in the COVID-19 task force, but we're also, through our strategy, we're intending that young professionals are actually part of the governance of ASFA, that they are involved not just as students to help with projects, but they inform the direction and the skill set, and they tell us what they need to learn, and we do it as a co-production, that if they're the young professionals, us old professionals are not custodians of all the knowledge. And that's the people on the task force. So I started to compose some thoughts on competencies in the pandemic, and they are, as you might expect, all the traditional ones on epidemiology, surveillance, assessment of effectiveness of interventions, advocacy, organisation, leadership, working in partnership and working with other disciplines. But there are also competencies for preparedness. And it seems to me that what goes wrong in any major disaster is not the emergency service. It's things like procurement, it's the public relations and communications to the press, made more complicated since social media. And it's also people dying of other conditions that aren't seen because of the emergency. And then, of course, you have the problems of recovery after post-traumatic stress, how to get services back to dealing with more routine business. So that I've also been asked to reflect on the idea of where public health fits in all of this. Public health is defined in European legislation as a medical specialty, but I would say it's a multidisciplinary profession, a service and a system. So we need all our health professionals to be geared up to public health. We need a stronger relationship with primary care particularly. But you know, we also need people, as I've said before, who come from left field, perhaps the engineers, the town planners, the ecologists, the climate scientists. All of these people have a vital role in 21st century public health. And I described that in a report, in a paper, ISIS, crop failure and no antibiotics. What training do we need for public health? So let me move on a little bit. Yeah, the other thing that we have in our strategy, which is quite important, I think, is we're part of a new global network for academic public health. And our sister organizations in Africa, in America, in Latin America, Asia Pacific, Southeast Asia, are all part of this global network. One of our first acts was to support the WHO with a statement. And we also published a statement around the disaster in Beirut. We are trying to work with the American Association and their affiliate, the American University of Beirut, to see what help we can give in relation to that continuing disaster. I think I'm nearly at the end, but we're obviously in the UK very exercised by our latest pronouncements from the Prime Minister yesterday, a one-way road to freedom, a cautious but irreversible plan, but we haven't quite seen how cautious and irreversible go together. So the final point that relates to the title of my speech is back to that idea that we are in a war, back to the idea that we can have a vision for a better world. And William Beveridge, who was the designer of the UK's welfare state, wrote his report in 1942, which was probably the lowest point of the war, the point where no end could be seen of that particular conflict. And he used the language of war to describe 5 giant evils. And those were want, idleness, ignorance, squalor, and disease, and that they should be the enemies of us all. And he said that is what the meaning of a social context, conscience, that we refuse to make our separate peace with evil. And the other notion that he had at the time was a country fit for heroes. And the other one was that we should plan for an outbreak of peace. And that is where I've taken the title of my presentation today, Planning for an Outbreak of Health. And I'm sure that all the people on this call will be up for the challenge, and any ideas that you have in support of ASFA, we will be producing a manifesto on planning for an outbreak of health. Please join us, and please join the comments now, and I'll be happy to try and take any questions. Thank you.
Thank you so much, John. It was a really fascinating presentation, quite rich with many information. So we can open the discussion, and I will wait for some Q&A box if there will be any questions. Maybe I can kick out somehow the discussion, and I prepared 2 questions. In fact, one more general, maybe, you know, recent pandemic, of course, highlighted the importance of public health. So it's really now very clear that public health is important. Now, in your opinion, how important it is to embed public health teaching in the undergraduate medical curricula? Some medical schools in the very crowded clinical curricula are considering importance, you know, somehow too important to cover only epidemiology and biostatistics, and avoiding other important parts of public health, occupational and environmental health. So the question is, how, you know, what do you think about this importance of the public health teaching in the undergraduate medical curricula?
Yeah, I think it's absolutely vital, and if people aren't persuaded by the need for it through this experience of pandemic, I don't know how they ever will be persuaded. We have lost a lot of the basics, really, of you know, infection control, how disease is spread, but also the root causes of infection and the root causes of you know, why some populations are more affected by disease than others. And you know, this is all essential basic stuff that undergraduate medical schools should cover. As I say, there's in 2 of our documents, the how to count illness is the one that's got the more technical knowledge of epidemiological methods and pitfalls and advantages of different techniques. But we have another document on basic terms on inequality. And again, if you want to understand why your patients are being ill, why some are more ill than others, then you need to have a basic understanding of societal impacts and influences on health. So it seems to me absolutely essential that we get that into the undergraduate medical curriculum. I know in my experience, it may be a long time ago, but 3 years nearly of biochemistry, and I don't know how much of that I do actually use at the moment, but you know, there's a need for a serious review of what does get taught in medical schools. Yeah. You're muted.
Sorry. Yes, these technical glimpses. Yeah, another question what I have, it is like related to your previous somehow position in the Faculty of Public Health, and it is related to the public health workforce development. In the last year and now still, it is very clear that many countries were lacking proper public health workforce. How important it is to include requirements for a set of practical skills to the training and licensing of medical or non-medical workforce. For instance, to have a residency program for public health doctors, or introduce the licensing process, which is not based only on educational degree, like only, for example, MPH, but also on some set of the practical skills.
Yeah, well, in the UK, we've had a multidisciplinary approach to public health training since about year 2000. We need our doctors, but we also need nurses. We also need professions allied to health medicine, and you know, they all bring different insights and different experience. The training program in the UK is competency based. So whatever you come into the training with, you have to go out with knowledge of all 9 areas of competence. And increasingly, when we thought we were bringing in the multidisciplinary, the disciplines would be environmental health, they'd be information scientists perhaps, but we've expanded beyond that. We've got historians, we've got geographers, and whatever background they come with, they have to be able to evaluate a high-cost drug or manage a meningitis outbreak, or they go out with all the competencies that the specialist training inputs. We're still also recognizing that we need people who are not going to be specialists in public health to be trained to have additional qualifications alongside their preferred profession. So GPs can go for a diploma in public health with the faculty, diplomate membership. Anybody can sit the Part 1 exam, so it does enable us to get more people trained and knowledgeable in public health skills. And I do commend it to people. I know in some parts of Europe it's very much a medical preserve, but the range of different skills and backgrounds that people come from, I think, is greatly enriching public health services. Yeah.
Yes, thank you so much. Another question, Dr. Mahmoud Sheikh Hussain would like to ask a question. Dr. Mahmoud, you can unmute yourself. I think that you are linked to the panelists, so you can unmute.
Yes, thank you very much, Professor John, for this comprehensive presentation. You have outlined, touched the global challenge and the national challenge. My question is, what factors that make this pandemic not controllable?
Sorry, could you repeat that, please, Mohammed?
Yes, you have outlined the challenge at global level, at the national level. My question is, what factors that make this pandemic not controllable, not controllable?
Yeah. Well, I think there's all the evidence of the speed of action, particularly in the Far Eastern countries, and preparedness. There was a will that they would not. They'd seen what SARS did, and they were prepared, and they knew how to act, and they'd been rehearsed. that they were prepared for a major outbreak of that kind. I mean, it could have been a major flu pandemic, but that they were prepared in a way that we weren't, and they weren't arrogant enough to think that they could control it without major measures. And indeed, even by the time it arrived in Europe and Italy, even when, you know, the bodies were stacking in the church of Bergamo, our Prime Minister still wasn't attending meetings of emergency preparedness, and major public gatherings were allowed to happen. And that was seen across the Western world, not in the UAE, I don't think, but you know, the actual mindset of preparedness. Indeed, in America, Trump had closed down Obama's pandemic unit. In UK, we'd had a major exercise on flu planning in 2016, which said we're short of ventilators and personal protective equipment, and nothing was done about that. So the mindset of preparedness wasn't there. But once the pandemic had taken hold, I think the other problems were certainly in the UK, probably in the USA, and some other Western countries. Years of austerity had actually disabled and weakened the population, such that we see these very high death rates in the older people, in ethnic minorities, in the north of England. And this was 10 years of austerity where we were already starting to see a decline in life expectancy in older people, and indeed in you know, from birth, actually, for women in working class families. So, you know, we weren't prepared, and then when we weren't prepared, we had people in worse health who were more vulnerable, and you know, I think all of these are key factors in how the mortality played out. Early on in the pandemic, it was looking as if, you know, countries with younger populations were being spared, particularly in Africa. But I think a lot of it was, you know, that testing wasn't widely available. And I don't think we can even rely on it being a disease that kills older people or people who are vulnerable. So those, I think, are the major reasons. Doesn't help when your government invests in huge amounts of technology of dubious value that actually can have a negative side as well. Some of the thoughts on lateral testing, for instance, that large numbers of false negative people circulating in the community and creating new outbreaks. So it's you know, by no means over yet. I seem to have missed a whole section of my presentation on vaccination, which of course UAE has done very well, and Israel, of course, and the UK close behind. But you know, again, we have to be very concerned that we don't just see our own countries, protecting our own countries as being the route to our salvation, unless, as people say, unless everybody's free of this virus, nobody will be free of it. There will be new variants, and it will continue to circulate.
Thank you very much indeed. It's very clear and highly appreciated. Thank you, Professor.
Unfortunately, we don't have too much time, but at least we will cover 2 questions from the audience. So first question is, thank you for the excellent presentation. You made hints on Brexit. Has it made obvious drawbacks to the pandemic management in the UK?
Well, ironically, the reduction in demand through lockdown has meant that a lot of companies stockpiled components for manufacture. A lot of supermarkets stockpiled food in warehousing, and the possible ramifications of Brexit in terms of damage to the economy and damage to food supply have not yet been fully realized. There are major concerns about particular industries like fishing, agriculture in terms of the workforce being available, in terms of things like fashion and music, where people need visas now to travel into Europe. So I think the effects of Brexit will be seen over a much longer period, and possibly not compounding the effects of the pandemic, but they will come along as we start to recover the economy, if we can. And so I think at the moment, Brexit has been not frontline news. I am very concerned about it, though, because, all of these moves, I mean, the finance industry has moved to Amsterdam. A lot of the income and wealth of the country has disappeared over into other parts of Europe. So adding further risks of recession and poverty for the already compromised and unhealthy mass.
And we'll ask, unfortunately, we don't have so much time. We have some more questions, but one question is, do you think if modern countries such as US, Gulf countries, Europe would have been done with the pandemic much earlier if they followed the basic guidelines from the WHO without any sophistications, much like Mongolia, Vietnam, and Uruguay did?
Yeah, absolutely. And, this is the danger. I think, I don't know if there are any modelers on the call, but, looking, I mean, it troubles me that we actually did look, we were watching the outbreak as it unfolded. We weren't acting on it. And so countries with much less sophisticated public health infrastructure did much better. And they understood very early on things like masking up. Some of the European countries like Czechia and Slovakia and Slovenia did very well early on, and they all used face masks from the start. Finland and Norway did very well early on, and still are, because they stuck to basic public health principles, really.
Excellent. So there are some couple more questions, but I think we have only 1 hour, so we need to end this webinar. So John, thank you again very much for accepting our invitation, for excellent, very thought-provoking presentation. I want to thank also those who made this webinar possible. So it is management, of course, of our college and UAE University who gave us green light, supported organization of the webinar, the organizational and technical team, Dr. Mahmoud Sheikh Hussain, Mr. Al-Sajir, and Mr. Ismail Al-Konaisi. Thank you also all of you who participated today. Our next webinar will be on March 23rd, it is Tuesday, and it will be postponed webinar from December about the public health in the Arab world. So please follow us on social media to find more details. So we look forward to see you next month. Keep well, stay safe, and goodbye.
Okay.
Thank you very much, Professor John, Michael. Thank you very much.
Thank you.
Thank you.
Thank you.
Okay, I'll send you a better version of the presentation. It all got, and I'll try and understand time zones a bit better. I thought I'd got half an hour.
No worries.
Sorry for this.
It happened not only you, several times it happened.
Yeah.
This.
Yeah.
Mm.
Anyway, okay. Thanks, everybody.
Thank you. Have
Thank
a
you
good
so
night.
much.
Bye bye.
Bye bye. Good night.
Bye bye.